Welcome to the Owens Recovery Science Podcast, where we dive deep into all things blood flow restriction training. I'm your show host, Johnny Owens, and whether you're a clinician, researcher, or athlete, you've come to the right place. Each episode, we break down the latest research, interview leading experts, and translate complex science into practical applications. We're here to bridge the gap between laboratory findings and real-world implementation. All right, welcome back to another Owens Recovery Science podcast. I've got the guys with me. It's been a minute since we've all been together. Ben Weatherford, Kyle Kimbrell, Zach Dunkel. Welcome back to the podcast, fellas. How's it going?
Good,
man. Yeah.
All right. I'm a little allergy ridden, so if I tap out, you guys are going to take over for me. So, or if I sound nasally, let me know. So today is going to be a breakdown of a paper from a good friend of ours. So I think it's a pretty cool pilot study because it maybe reinforces some of the things that we've been talking about and teaching for a long time. But this is from Germany. Y'all want my German accent?
Yeah, absolutely. 100%.
Alec Franz. Alex Franz. So if y'all have not listened to our previous podcast, what the hell is wrong with you? But we've had Alex on before. I think it was episode 49. He's part of our group. Years ago, he was teaching our ORS courses over there in Germany. He's a busy guy now, so he doesn't really do that as much anymore, but just his background, he's an orthopedic surgeon, focuses on total joints, and he's at Atos Orthopark, but also what's really badass is he runs the research component for the orthopedic department, and what's even more badass is he's an orthopedic surgeon who's very interested in rehab outcomes in orthopedic surgery. And especially for us, he's a big BFR guy. So he's really churning out a lot of things. He just published this paper, and then another paper came out this week. And he's not just doing orthopedics. He's got an ICU study that's ongoing. He did an indwelling catheter study. But this is his second total joint study. So he did a prehab study for, was it total knees and hips or just knee?
Yeah, it's total knee.
Total knee, yeah. Which protocol was a little bit wonky to implement, we thought, but it was BFR on a bike and showed really interesting and positive outcomes even months after the surgery. And so this new paper is titled Passive Blood Flow Restriction Exercise Impact on Muscle Atrophy Post-Total Knee Replacement, a Comprehensive Breakdown. And so basically, here's the overview, and it's in the Journal of Clinical Medicine. The overview is, we all know after you have a surgery, especially a big joint surgery, you are probably going to lose muscle mass. And so the average amount of muscle mass loss in the operated leg that they cite is around 14% after TKAs and 7% in the non-operated leg, and that's within the first week. So there's just a big muscle dump that happens after this big traumatic kind of procedure. We know it's typically older muscle, and he goes into a couple things here, and I think we should kind of talk about this a minute. And it makes sense, and we know this, but catabolism goes up after you have these big surgeries or big injuries, and what that means, obviously, is your body starts to break down. And specifically, he cited that it's been found in the total joint literature is that there's an increase in the FOXO gene expression, or what muscle ring finger 1, which is kind of a downstream effect of that. So MRF1, and maybe MRF other numbers. I don't know all the damn MRFs. I'll let Zach deal with that. Just CrossFit workouts. So anyways, those upregulate. And when those upregulate, you start to get muscle breakdown. So they're catabolic. So if you can downregulate or block the increase in that MRF gene, FOXO gene, then maybe you could preserve muscle mass. And so that was kind of their hypothesis of using this. And they mentioned you should maybe go after those specific gene expressions. And so what we've taught and what we've seen in prior publications is that in a disuse model, if you just put a tourniquet on and increase it for around 5 minutes on, 3 to 5 minutes off, typically for around 3 rounds, we used to call it cell swelling, then passive BFR, and really I think we just should call it remote ischemic preconditioning. It mitigates the muscle loss compared to doing nothing. We know BFR increases anabolism. So we see an increase in things like muscle protein synthesis when we do BFR with exercise. But when you've done this passive application and they've measured muscle protein synthesis, we know it doesn't go up. So it's not as anabolic, but a study several years ago biopsied when they did this passive application and showed that there was a blunting of that MRF gene when you did it, and you had less muscle loss. So basically, we know that from a gene expression profile, if you do this passive application, ischemic preconditioning application, you should blunt that MRF gene, and you should see preservation of muscle. That's my take on their discussion going into this. You guys have anything y'all want to add or talk about MRF or anything?
Yeah, I mean,
I thought that was pretty good.
Yeah, that's the big thing is, whenever I talk about, especially total knees and whatnot, basically 80% of the atrophy that you see over the first 6 weeks is occurring within the first 2 weeks. And the big downs or the big thing that we have to worry about is, it outside of a physiology lab type setting, you have to manage the client patient along with managing this muscle issue that's going to cause these sequelae of situations downstream. You have pain, you have the tolerance to doing activities, you have swelling, range of motion issues, all these things you're trying to manage, but then you're also trying to say, well, we got to do something because this muscle's just atrophying away. And so, yeah, I think that's where ultimately the idea for this comes in, is a little bit of something, maybe better than nothing, until we're able to control for this, this loss of muscle and actually start doing active exercise.
Yep.
All right. I mean, I was going to say the only other component for me that I really like about this, we're going to get into the details of, is how quickly we know that loss happens. I mean, we've gone into that on other podcasts, but it's just the decrease in protein synthesis and how quickly the upregulation of some of those catabolic things seems to be happening. I mean, it's within the first few days.
Yeah.
I mean, it's not a week where we really start to see this start. It's really 2 to 3 days from what we know. So it's that sense of urgency to figure out, well, what do we do to make something happen in this time point to play some defense?
And this is where Alex is badass, if you listen to our podcast, is because he says at his institution, after their total joints, he had it cleared where they can start BFR day one. And he said, if you are nervous about your incision, surgeon, then you might need to work on your suturing techniques more, because that's kind of thrown at us as well. I'm worried about the suture, or, we can talk about things like VT and all that. But they at Atos Orthopark, he has it where they are starting this basically immediately, which is huge. If we know MRF goes up day one and we start seeing by day 2 or 3, even on MRI, this loss of muscle, if you can get this started immediately, then that's badass. And so he put his money where his mouth is, because he made that statement, and now he's published a paper with a trial where they started this intervention day one, which is pretty dope. They're tougher in Germany, I guess. Their BMI was higher than ours too. I looked at the average. I was surprised by that.
Really?
Yeah. Oh, to get into the study design here, it was 26 patients, so it's just a pilot, 16 female, 10 male. Average age was around 64, and it was 21 primary TKAs and 5 revisions were included as well. That were revisions for aseptic loosening. Pilot, but still enough people that I think we can kind of be happy with what the data shows. The application, obviously everything Alex uses over there, they use the Delphi system. So they did Delphi's at 80% limb occlusion pressure for this passive application, which is different. What do you guys thought about that? Because typically we would go at 100%. Was it? You think it's a tolerance thing? I need to talk to Alex and see like why he chose.
Yeah, I don't know.
Yeah, I'd be curious to know. I mean, in most of what we see with the 100% occlusion, we'll see the term of IPC, RIPC, like you mentioned,
Mm-hmm.
and it's typically the 3 rounds of 5 minutes on, 5 minutes off. So yeah, maybe for tolerance, they chose a slightly lower pressure, and that's why they did more inflations of the cuff, and they bumped it up to 5 instead of just 3.
Yeah.
I mean, nobody's really done an 80% pressure anyhow. Jamie Burr did 100%, and I think we look at like the Natsumi paper and the Kubota papers and those 220. We kind of look at those and go, all right, they're pretty close to 100%, but we don't know for sure. So, I think they were using a high pressure, which I think we feel like if anything, we could kind of put our stamp on and say, this is what we think we know. It's got to be a relatively higher pressure. But
medical grade tourniquet, which we know we're getting that 80%, and some of these papers that shown things, they're not using that kind of system, and they're just picking a number. So yeah, it's kind of cool. Like maybe we can go at 80%. And Ben and I talked about it, and it's also can set you up for the exercise component.
Right.
You do this, and we'll talk about it more in the state of design, and they're already used to 80% of this, and now it's like, okay, so let's start adding a little bit of exercise, because 100% occlusion is very hard to do exercise.
Yeah,
that
is true.
And so they also went a little longer, according to Zach, way longer. Almost twice the time, man.
I mean, you did.
Zach all worked up. So they went, instead of going to a typical 3 rounds of 5 minutes, they went 5 rounds of 5 minutes. So instead of this being around a 30-minute application, it was around a 50-minute application. But they do things differently in Germany. So they did this in the hospital setting. So after a total joint there, I guess they're in the hospital for an average around 6 days, which is totally different than the way we do it over here, and that's something we'll talk about here in a little while. We typically are out the day of or the next day, but maybe they just had time to sit around and eat Jell-O and be there for 50 minutes. So what we don't know is, would 3 minutes do just as well as 5? And maybe because it used 80%, he wanted to extend the time a little bit more as well. But that's what's different. 5 rounds, 5 minutes on, 80% limb occlusion pressure. And they started day 1, and they went for 5 days. That's the study protocol. Control group did a sham. Daily. Mm-hmm.
Yep. Alternating inflations.
Inflation.
One leg on, the other leg off, and switch.
Yeah, which is kind of standard. People always ask about that. I haven't seen any. I know Alex put some stuff out there. Maybe when we talked with him, maybe it was a paper, I can't remember, about bilateral alternating or not alternating when you do this. Only thing I can say is why you wouldn't do it at the same time is tolerance, right? It's just a tolerance thing. I mean, I'm not feeling unsafe with that, but you guys feel the same. Okay.
And to me, it's the passive versus with exercise, right? Because if it's exercise and you're doing something that is a bilateral movement, instead of doing one at a time, knock out both at the same time potentially, versus passive. If you're just laying there, it sure is a little bit more tolerable. Feels a little better if you're alternating.
Yeah, if you have the time, it feels better. I mean, I like to alternate if I'm just sitting around doing nothing. But I did a webinar for an NFL team the other night on ischemic preconditioning, and that was their question. Like, can we just do it at the same time and get this over faster? Yeah, I think so. Okay. Outcome measures. Primary was muscle mass. I'm sorry. Don't get Zach pissed off again. Lean. What is the term you want me to use?
Lean mass.
It's lean mass. What a DEXA measures is lean mass.
All right. Lean mass on a DEXA. And thigh and knee circumference tape measure. So we have an imaging, we have a measure, and then secondaries. Safety was in there, but I'm throwing the secondary outcome measures. Is 6-minute walk test, chair rise test. They also did grip strength, which is interesting. Patient reported were also outcome measures. KOOS SF36, And they did baseline. So prior to surgery, they took all these measures. And then they did at or discharge at around 6 days, 6 weeks, and 3 months. Cool. Did I miss anything?
All right.
Study design? All right.
I think so.
Key findings was there was muscle preservation. So at 3 months, the control group had lost around 8%, a significant amount of muscle mass in the control group. And the intervention group basically was at baseline, so didn't lose any mass at that 3-month mark. There was a between group difference. And so this is thigh circumference. Sorry if I said lean mass. The between group difference was there at 0.002. So thigh circumference was winner for the BFR. Lean mass on the DEXA. The operated leg, the control group lost significant mass while the BFR group was able to maintain that. I don't know why I didn't write my time points. Do you guys have the time points?
2 and 3.
Mhm.
2 and 3.
Yeah.
Okay.
Yeah.
Yeah. So that's pretty badass. So 6 weeks and 3 months. You do see an increase in mass post-surgery. If you look at the graphs, it's a little misleading, but that's just the swelling that was in the limb. But to basically maintain that at 6 weeks and 3 months with a 5-day intervention is pretty sweet. And their rehab they were doing in the hospital besides this was just passive range of motion, CPM, gait training. So they weren't doing any other intervention in the hospital. Whole body lean mass declined in the control group, but increased in the BFR group. And they also saw preservation of the non-operated leg on DEXA, only lost around 3% compared to the control group that lost 7%. Any thoughts on the muscle side? That's all badass.
Yeah, I mean, I was really kind of, I thought it was cool that they looked at the non-op side, because it was kind of like, when I read that, I was like, dang, man, I never really rehabbed the non-operative side in my total knees, and you sure should be, you sure.
Well, like Luke said, Luke in their ACL study, they had to do the same exercises on the non-op leg. The NHS requires them to
really
to do that. Yeah, so maybe these Europeans are smarter, fatter, and smarter.
Well, I mean, it's also nice to just corroborate some of what we've seen in these other passive BFR during disuse papers in a post-operative total joint study. I mean, so seeing that it translates over to more than just the physiology lab and getting it into something like the total joint is cool to see.
This is the banger population, man. I mean, I've been wanting to see a passive in a total joint trial because it's just, I mean, my mother-in-law, I didn't do it on her because I don't treat my mother-in-law, but she's had a total knee, and the amount of pain that first week, it's just hard to get her to do anything. And so if you can just get this on there, and there maybe is some endogenous opioid release. In my IPC talk I did the other day, there is some upregulation that they've seen in that. So maybe they're getting a little bit of pain relief as well. It's pretty badass. But so far, what I love is day one, let's go. They did it. And we've got an objective imaging measure that showed improvements, as well as the, not as objective, the thigh circumference measurement. All right. This one's good too. Go ahead.
Back up to the thigh, Johnny. If you look at, they reported the thigh and knee, and so that ultimately just looks at swelling, right? But if you look at the knee, the intervention group actually had a smaller increase in circumference of the knee than what the control group did, and that actually reached significance as well. So there's potentially what you're looking at is the amount of joint effusion that's going on. So that intervention group that got this passive protocol actually has better joint effusion than what we get out of the control group. Kind of what Luke showed as well. With exercise. So that's another benefit too.
Yeah, at 6 weeks and 3 months, they already showed the effusion was better.
Well,
so you got Luke's paper.
They showed this at discharge from the hospital at T1. there was a
Really?
difference between
Okay.
groups. That then at the 6 week mark, it returned back to baseline in the intervention group, still remained elevated in the control group, and then was still elevated at 3 months in the control group compared to the intervention group, who's still at baseline. So
I wish more of these clinical trials would measure the effusion in the joints, I guess, because it's not measured. But I remember Walt Lowe was like, have you guys noticed that like, for some reason, these BFR people, after their ACL's knee is not nearly as swollen. And we were just like, well, it must be maybe they're preserved muscle and they're walking better or whatever. But I don't know.
yeah,
Alex talked about some of the mechanisms in there. Have you guys done any deep thought on mechanism of why the effusion's better?
yeah, it's hard to say. Could it be a vascular issue? You
Mm-hmm.
know, where you're just, because all you're really doing in here is just like inflating, deflating that cuff. So
Mm-hmm.
could that basically create a pumping mechanism? Maybe I don't know. Maybe an inflammatory marker, kind of an effect. But
Yeah, because there's three prevailing remote ischemic preconditioning like lanes. The one is the humoral response, which so
Yep.
it's this blood thing. Then there is the neural response, vagus nerve change, and all that. But then the third and big one is the immune response, and you see
Yeah.
a big reduction in inflammatory cytokines and changes in white blood cells. So that alone
Yeah.
might be.
Yeah, so you get a downregulation of interleukin 6 and an upregulation of interleukin 10. Interleukin IL-6 is your pro-inflammatory marker, so that gets driven down, and then IL-10 has been shown to be upregulated, and that's your anti-inflammatory marker. So,
Why do they
maybe
make them
there
the
is,
same name? Just messes me out.
yeah. So maybe there is a bit of a carryover, into this, and we see that, and then that just like sets the stage for what goes on
Mm-hmm.
in the following weeks.
Yeah, well, and I knew that wrist radius fracture study, but I never really, I guess, read into it. But he also mentioned that one showed reduction in swelling. Did y'all see that?
Yeah.
Yeah, and that's always a swollen, painful kind of group as well. So
Yeah.
okay,
Yeah.
just swelling reduction, functional outcomes. Okay, here's where we get a little bit contentious on what we were all seeing here. But at the 6-minute walk test at 3 months, the BFR group improved around 24% above baseline, and the control group decrease was still down 7% below baseline. Okay. That reached significance, but not really. I got in my notes 0.001, but then in discussion, they said they didn't reach significance. So again, I'll have to talk to Alex and figure out what was true there. And we were going back and forth. But here's the most important part. The minimal clinical important difference. So the MCID is probably more important than anything else than significance. And so in a 6-minute walk test, if you improve by 26 meters, that's clinically important. And my calculations on the percentage it went up, it improved by 102 meters in the BFR group. So that's a that's a huge clinical meaningful difference, right?
Yeah, and I think the other thing you look at too is when you look at the effect size, that's a moderate to large effect. It was Cohen's D was 0.73.
0.8. Yeah, I think it was almost 0.8.
Yeah. So where was it at? It was 0.85. For a between group difference at 3 months in an intervention group, pre to post, was 0.73. So yeah, so you may not get
Big
a
effect
statistical
size, big clinical change.
That's a good difference pre to post, and a moderate to large effect between groups. So and this is the thing I think you go back to, the only thing that you really did different was you put a cuff on and you just alternate inflation, deflation. That was it. There's no difference in exercise or, anything. So pretty easy to implement, pretty easy to do. By all accounts, it's safe. And you're getting these changes in muscle, and then you're getting these functional changes at 3 months. That's a huge difference.
Maybe you don't need rehab. You just need this for 5 days. walk out.
That's it. Chat
Just
GPT
too damn long.
and Chat GPT and just alternate some inflations and deflations.
The grip strength group. So grip strength, the BFR group recovered their grip strength at 3 months. The control group was still reduced. I don't have in my notes. What did we have on the chair?
No difference.
No
change.
Improved
No
in both
difference.
groups. No difference between
No
groups.
difference, but the BFR group increased it by 3.1 reps, and the minimal clinical change is 2 reps. So they did have a minimal clinical change as well. I can never say that. I can't do the acronym right.
MCID, that?
MCID. I always say MCDI. When I try and say minimal clinical, it just messes my mouth
Now say
up.
it in German.
Minimal clinical change.
It's weird. It sounds just like your...
Was ist das?
I mean,
It's
that
just like
sounded
the Wales
a little-
accent.
Scheisse, Kyle, Scheisse.
That sounded a little
It's like
Indian
Alex is here with us
and
today.
A little Indian/German.
Yeah, that's what I am. Curry kebab or whatever it is. The curry bratwurst they always have over there. You guys like that? Always
Germany?
get it at
They have curry
Oktoberfest.
bratwurst?
Yeah, it's a big deal.
I've
over
never
here.
had that.
All right. Coos, no difference, but the BFR group increased by 16 points. Got to get it above 12. So again, meaning minimal clinical important difference. And SF36 increased by 9 points in the BFR group. You just got to get above 7. So the control group didn't reach a minimal clinical difference in anything except for the chair stand, right? Yeah, only crossed the noticeable line on the chair test. So I think all the functional scores, even though the discussion kind of downplayed it, were fucking badass, maybe even better than what we saw from just muscle mass, from those large effect sizes and those changes in their clinical importance. All right. Safety, lastly, no reported adverse events and 100% compliance. Everyone was able to do it. All right. So it's feasible. This can be done, like Zach said, super easily. Start it as fast as you can. It is always our go-to. Protocol's 5x5 in this study at 80% LLP, but we don't know 3x5 at 100% LLP, 3x5 at 80%. But this passive application lived up to the hype that we've been talking about. Limitations, though, small sample size. It's only a 3-month follow-up. And the thing I guess that we need to talk about too is how do you implement this in America? And God bless USA, where we get our people out of the hospital quick, damn it. There. So, it's get it on as fast as possible. But, if they come see you 2 weeks out, it still might be worth doing this if they can't tolerate BFR and exercise, but at least getting the tourniquet on them and is going to do something. And so I think that's always a thing, like we'd hear from these total joint docs, like, I want to wait, 6 weeks or 2 months later. But if you get these people in your clinic fairly early, rather than just doing range, man, just get the tourniquet on them. It's a good start.
Yeah.
I don't think range of motion does anything physiologically to a knee, make it adapt. Like, what does range do? Nothing.
Yeah, I think the thing in the U.S. where the avenue where this goes is if you have a relationship either with a total joint doctor or you have relationships with clients before they go and get a total joint, and they're going to see you relatively quickly. I mean, that's the avenue in the clinic. The other avenue is on the home health side of things.
Mm-hmm.
And again, the feasibility side is it's not cumbersome to bring the unit, to the house and whatever. And if you do something for an additional, 3 minutes, you got yourself 4 units right there.
There you go, baby.
And it's better than the home health walking club,
Yeah.
You be feeling like a ninja, like I'm taking down the Murph gene, baby. Let's go.
That's it. Math box and Murph 1, baby.
Yeah. IL-6 up, IL-10 down, or vice versa. I don't know.
It's vice versa, actually. Yeah.
Well,
Alex,
I mean,
Alex did point out that he thinks the prehab component is really valuable, and maybe we would see better functional changes if you kind of got these folks conditioned up a little bit, which obviously we all agree with. It's just, can you get these people in ahead of time? If you do, man, hell yeah.
Well, and I think it's important that I feel like we do a good job of talking about this, but these people have already been in that state of catabolism, depressed muscle protein synthesis. All of those things are already going on because of the pain and limitation in using their limb. And then, of course, they're going to get this spike of all of that when they have the surgery and the environment changes dramatically again. So, addressing it prehab, continuing to address it post-op sure seems like the real formula that needs to be implemented.
Perfect protocol would be, could you get them in 4 to 6 weeks prior, apply this for 5 days post, and then move into BFR and exercise till they can tolerate load, and then go to Disney World, Grandma Smith. You're kicking ass, lady.
You've earned it.
Well, I think this is, obviously the first step in the process of answering the question, what can we do after surgery? How quickly? With what kind of intensity? The question that we get a lot is, okay, how early after surgery can I really do this? Does it matter what type of surgery it is? And with the total joints, there's always been a little bit more of that fear avoidance of, I don't know. And people are giving me more questions than I have answers to. And, can I really push this that early? So we have at least some tolerance of no adverse events, pretty high pressure, multiple inflations done daily. And now the question is, okay, can we add exercise to that? And is that still tolerated the same way, which it seems like it probably should be? And especially if we add that prehab component of them being somewhat familiar with the tourniquet before the surgery, so they're not scared of it, because after surgery, everything hurts, and we're trying to get them to do something else that's also uncomfortable. So if they're already, familiar with it, they've done it before, they know what it feels like, smells like, and, they're more willing to push it, then, it seems like we're kind of hitting it from both sides. It's hitting all those positive targets for us. So,
well, and the biggest thing, and Kyle, I'm going to present this in our CSM talk next year. Why aren't we doing this in acute care? If you do have people that are going to be there for a week or 2 weeks or whatever, with whatever their problem is, man, I mean, if it does this for a total knee, I'm sure it can do it for all these other conditions.
Perfect for
same physiology.
For our talk. Yeah.
Yep.
Because you look at what they did here, and I'm going. I think what ends up happening is clinicians will look at this paper, and they'll go, okay, I got to do that exact thing, And so they'll do all the passive things, and because this is exactly what the paper did. But I look at that and I go, wow, this is awesome, because they started bottom of the barrel, and there's so many opportunities to scale what you're doing in the hospital. It's like maybe day one it's all passive, but day two, why don't we just do some quad sets during the first 2 inflations, and then maybe day 3, maybe that first inflation, you're actually doing it just standing at the bedside, just kind of shifting your weight back and forth, and then by the end of day 6, maybe the last 2 inflations, you're actually just walking, for those last 2 inflations with the cuff inflated. There's so many opportunities to just add little bits of activity to those 5 inflations and get people gradually doing a little bit more. As long as, of course, everything is tolerated. But that's our job, is to figure out how to scale this stuff so that we can get people more active. But I think the mistake that's made is just looking at this and going, oh, okay, for the first 6 days, I have to do 5 on, 5 off, 5 rounds at 100% or 80%. And I would say, no, absolutely don't do that. That's how studies have to be done. But as a clinician, you're going to be like, okay, I can add this and I can add this and I can add this.
Like Steven said, when we did the IPC talk, if you can add exercise to it, it's even better, right? And maybe, Kyle,
Yeah.
you would even treat their uninvolved limb.
I might,
eventually.
you never know.
You never know. The whole body.
They're walking on it. What do we?
Yeah, I would say that the biggest, easiest thing, even outside of the progression that Kyle just laid out, I just throw some neuromuscular stim on this thing, and get a good muscle contraction out of that, and go from there. I mean, I think we've all have looked at the cell swelling, the IPC in this context, as a proof of concept. Does it have an effect? And it looks like it does. But you always want to maximize what you can do. You want to do the most that individual in front of you can do. So maybe all they can do is an inflation deflation deal. But the vast majority of people, you can throw some stim on them and get a good decent contraction from there.
I agree. All right. Well, good job, Alex. Franz, we'll have him back on because he has so many freaking studies going on right now. But I love this initial pilot, and I hope we can get some build on this. And maybe after our talk at CSM, Kyle, we'll get all these acute therapists excited, and they'll start applying it in the hospital, and we can spin off some more studies.
For the record, Johnny said acute therapist. He didn't say we'll get. I mean, he might have said those cute therapists, but
acute therapist.
Acute.
That's why I have you there,
acute
Kyle.
care therapist.
Acute therapist.
Yeah, that's why I'm there, to be the
You're like
cute
a teddy
therapist.
bear.
Yeah.
All right. Be sure to check out recoveryscience.com if you want more information. We have podcasts, we have blogs, we have courses all over the place. There's the new Delphi Gen 3 system that's out that is badass. So you can reach out to inquire about it. It's bilateral and selling like hotcakes right now. So limited supplies, but if you're interested, reach out. And as always, appreciate you listening. If you like us, subscribe and click that like button. Thanks, fellas. I gotta go pee.
On.
Cheers.
Take care.
I'll do that. Thanks for tuning in to the Owens Recovery Science Podcast. Before we go, a quick reminder that the information discussed on this show is for educational purposes only and is not intended as medical advice. Always consult with your healthcare provider before making any changes to your treatment or training regimen. For show notes and additional resources, be sure to check out owensrecoveryscience.com. And don't forget to like the show and subscribe for more evidence-based insights. Until next time, earn your deflate.